Welcome back to the deep dive. Our mission today, well, it feels pretty urgent, actually. We're digging into a class of really common medications. And according to our sources, particularly insights from a brain health specialist, these meds might be quietly damaging cognitive function. We're talking about potentially increasing dementia risk significantly down the line. So if you take anything for, say, sleep, allergies, maybe an overactive bladder, you definitely want to listen closely today.
Absolutely. And let's just be clear about the stakes right away. We're talking millions of people taking these compounds every single day, often thinking they're, just minor aids, maybe completely harmless even. But the source material, which draws on, years of neurological practice and some pretty significant studies, argues the evidence for long-term neurological harm is frankly overwhelming, and it often builds up silently, accumulates over time. And the tragic part, it's frequently missed, overlooked.
Okay, so let's define the target here, the enemy, so to speak. We're talking about anticholinergic medications, ECX for short. And the reason we're doing this deep dive now is because patients, maybe people just like you listening, are starting to notice some really alarming cognitive stuff. Things like struggling to remember names, that persistent kind of mental fog, or maybe that awful feeling when you just can't find the right word. And they're finally starting to wonder, could it be connected to those medications? The ones their doctors might have said were, perfectly fine for long-term use.
And the science behind this concern is, it's incredibly solid. What's really fascinating, or maybe alarming, is how directly these drugs hit the brain's operating system. You see, anticholinergic drugs work by blocking the action of acetylcholine. Now, acetylcholine isn't just any neurotransmitter. It's absolutely crucial, essential for memory formation, for learning new things, for maintaining attention, even executive function. So when you block acetylcholine, the brain just can't communicate effectively within itself. It literally inhibits the processes you need to learn, to remember. That blocked communication, that's the root of the cumulative risks we need to unpack.
Okay, right. Let's unpack that. So if you're blocking the brain chemical most vital for memory, what does the source material say actually happens to your brain over time? The neurologist we're citing points to 4 pretty devastating effects observed in patients using these meds long term.
Yeah, 4 key things. And the first major one is progressive memory loss. And here's the kicker. It dangerously mimics early Alzheimer's disease because, you see, these anticholinergic drugs inhibit the very same neurotransmitter system that Alzheimer's disease targets. So the neurologist argues, quite forcefully actually, that taking these medications for years is, the quote is, essentially giving yourself chemical Alzheimer.
Wow, chemical Alzheimer's. That's really shocking language. But You mentioned data backing this up. A 54% increased risk of dementia, you said. That sounds huge.
It is huge.
How long does it typically take to reach that kind of risk level? Are we talking weeks, months, or is it years of use?
Right, that's the critical question. And the source is very clear. This risk is directly tied to the cumulative dose and the duration of use. The main data comes from this landmark University of Washington study. They monitored over 3,400 people, all over 65, for 7 years, and they found that consistent cumulative use led to that staggering 54% increased risk of developing dementia. So we're generally talking about long-term, often daily use here, not, taking one Benadryl because you got stung by a bee. This damage really compounds over years.
Okay, so memory function is impaired chemically, but what about physically? What does the source say is happening inside the brain itself? You mentioned a second major effect, irreversible brain atrophy.
Exactly. This isn't just about feeling foggy anymore. This is visible, physical damage to the brain structure. Research out of Indiana University School of Medicine used MRI scans, and what they found was that people taking these ACH drugs had significantly smaller brain volumes, particularly in areas like the temporal lobes and the hippocampus. These are the absolute key areas for memory and learning.
That's truly sobering. And let's pause on that idea of permanence for a second, because the most terrifying nugget, I think, from the source, is that some of this brain shrinkage might actually be permanent. It might persist even after someone stops taking the medication.
Yes, that's the concern. The longer the exposure, the higher the likelihood of some lasting structural changes.
Okay, so memory loss mimicking Alzheimer's, physical brain shrinkage. What's the third effect?
The third observed effect is accelerated cognitive aging. Basically, your brain performs like it's much older than it really is. When they do neuropsychological testing on people using these drugs long term, they often perform on memory tests as if they were, say, 10 to 15 years older than their actual age. So you might have a functionally healthy 60-year-old, but their memory tests look more like someone who's 75, and that obviously has a huge impact on their quality of life, their independence.
Definitely. And the final one, the fourth effect.
Yeah.
This one seems like the most immediate physical danger and increased risk of accidents.
Yes, severe physical accidents, because these drugs don't just cloud your memory. They also impair balance, coordination, judgment, even reaction time. And this leads directly to things like life-threatening falls, dangerous episodes of confusion, especially in older patients. The source points out that emergency rooms frequently treat older adults for falls that were likely caused or worsened by these drugs. But often the connection isn't made. The prescribing doctor might not even know about the fall or connect it back to the medication they prescribed.
Okay, this is a lot. If the evidence is this strong, linking these drugs to dementia symptoms, brain damage, falls, it begs the question, doesn't it? Why on earth are doctors still prescribing these medications so routinely? It seems like a massive paradox.
It really does, a huge prescription paradox.
Right.
And the source actually outlines 4 main systemic reasons why this keeps happening.
Right, let's go through them. The first one you mentioned is medical education just lags behind.
Yeah, essentially. Medical knowledge, especially around long-term effects of older drugs, can take decades to fully filter down into standard practice. Many doctors were trained before these specific long-term brain effects were well documented, and they might not have updated their understanding on this particular class of drugs.
Okay, that makes sense. What's reason number 2?
Reason 2 involves, well, commercial pressure, let's be blunt. Drug companies make a lot of money from these high-volume, frequently prescribed medications, and historically there's been a tendency to minimize or downplay potential long-term neurological risks when marketing these drugs to prescribers.
Right, okay. Number 3 is about focus, prioritizing the immediate problem.
Exactly. Doctors are often focused, quite understandably, on treating the acute symptom right in front of them. Relieving terrible seasonal allergies, helping a patient get some sleep tonight. And in doing that, they might not adequately weigh the potential long-term cognitive costs down the road. If the immediate problem seems solved, the prescription feels like a success in the moment.
And the fourth reason. This seems to bring it right back to the patient, to you, the listener.
It does. Patients often don't make the connection themselves. If you start experiencing memory problems, you might not immediately think it's related to that allergy pill or sleep aid you've been taking, maybe without thinking, for 5 years. And because the patient doesn't bring it up, doesn't mention, hey, since I started this pill, I felt foggier, the doctor might never investigate that crucial link.
So to make this really concrete, let's talk about that case study the neurologist provided. The 68-year-old patient, this sounds like a classic example. She came in absolutely terrified, experiencing rapid memory decline over about 3 years, convinced she was looking at early Alzheimer's.
Her decline was genuinely devastating for her and her family, but her medication history was the key clue that others had missed. Turns out she'd been taking diphenhydramine, the active ingredient in Benadryl, and many other nighttime sleep aids every single night for 5 years, just to help her sleep. And on top of that, she was also taking oxybutynin, another potent anticholinergic, for an overactive bladder, and hadn't for 3 years.
So 2 potent anticholinergics daily for years. Her previous doctors hadn't connected the dots, but this new team did.
Immediately, they saw the anticholinergic load and flagged it. The first step was to carefully discontinue both medications. Then they transitioned her to brain-safe alternatives. For sleep, things like melatonin, magnesium, focusing on better sleep habits, sleep hygiene. And for her bladder issues, they switched her to a non-anticholinergic drug called mirabegron, along with some behavioral strategies.
And the outcome? Did it help?
It was remarkable, according to the source. Within just a few weeks, she reported the mental fog starting to lift. Within 3 months, her memory had improved significantly. Follow-up cognitive tests showed really dramatic improvements in her ability to retrieve information and her working memory. And maybe most crucially, a follow-up MRI scan taken a year later showed no further brain atrophy. She had effectively stopped the chemical damage and achieved significant cognitive recovery.
Wow. Just by removing those drugs, that really proves recovery is possible.
It strongly suggests it, yes, especially if caught early enough.
Okay, this is vital information. So if you're listening, if you are the learner, you need that checklist now. What are the most common medications we're talking about here? What names should you look for?
Right, let's break it down. The source groups them into 5 main categories: The first big one, first-generation antihistamines. This includes things like diphenhydramine again, Benadryl, Unisom sleep melts, many PM medications, also chlorphenamine, hydroxyzine. These are often in over-the-counter cold, allergy, and sleep products precisely because they make you drowsy by blocking acetylcholine.
Okay, got it. First-gen antihistamines. What's category 2?
Category 2 is huge, especially for older adults. Overactive bladder medications. We're talking drugs like oxybutynin, tolterodine, sulfasenacin. The source notes, these are very commonly prescribed, and some have particularly strong anticholinergic effects.
Right. Category 3.
Third are the tricyclic antidepressants. Now, these are older antidepressants, but drugs like amitriptyline and nortriptyline are still frequently prescribed today. Not always for depression anymore, but often for things like chronic pain, nerve pain, or migraine prevention. They have significant anticholinergic properties.
Okay, number 4.
Category 4 covers anti-vertigo and anti-nausea medications. Think of drugs like meclizine, often used for dizziness or travel sickness, and promethazine. Again, effective for the symptom, but potentially costly for the brain long term.
And the last one, category 5.
The final category mentioned is muscle relaxants. Specifically, the source calls out cyclobenzaprine, which is often given for short-term back pain or muscle spasms. It also carries strong anticholinergic effects.
That's quite a list, covering really common conditions. But the good news, the encouraging part, is that the neurologist insists there are brain-safe alternatives for almost everything here. For allergies, for instance, ditch those first-gen sleepy ones.
Exactly. Switch to second-generation antihistamines like cetirizine, loratadine, fexofenadine. These generally don't cross the blood-brain barrier as easily and have minimal anticholinergic effects. Or, even better, address root causes through diet or environment if possible.
Right. And for sleep, definitely stop using things like Benadryl nightly.
Absolutely. That's a key takeaway. For sleep, the focus should be on things like melatonin, maybe magnesium, improving sleep hygiene, consistent bedtime, dark room, no screens. And for persistent insomnia, cognitive behavioral therapy for insomnia, CBTI, is considered the gold standard. These approaches target the reasons for poor sleep without chemically impairing your brain.
Makes sense. What about overactive bladder?
For OAB, the alternatives start with behavioral changes, pelvic floor physical therapy. If medication is still needed, the drug mirabegron is a key option because it works through a completely different mechanism, avoiding those anticholinergic side effects.
Okay, and finally for depression, if someone's on an older tricyclic.
The strong recommendation is to discuss transitioning to modern antidepressants like SSRIs or SNRIs, which typically lack significant anticholinergic effects, and of course, always complementing medication with therapy, exercise, and good nutrition.
This is incredibly helpful. So it sounds like alternatives exist, which brings us squarely to the action phase. What's the single most urgent recommendation for someone listening who thinks, wait, I'd take one of those?
The recommendation is clear and urgent. If you are currently taking any medication on that anticholinergic list, especially long-term, schedule an appointment with your doctor or healthcare provider immediately. The specific goal is to discuss brain-safe alternatives for your condition. And crucially, the source emphasizes, do not just stop these medications abruptly on your own. Some, particularly antidepressants or even long-term antihistamine use, can require a careful, gradual taper to avoid withdrawal effects. This needs medical guidance.
Okay, so make the appointment, and when you go, how should you approach that conversation? Communication seems key here.
Absolutely. You need to be prepared and assertive in a collaborative way. Bring documentation, or at least be ready to clearly describe any cognitive symptoms you've noticed since starting the medication. Mention the memory problems, the word-finding issues, any confusion, that mental fog. Spell out the timeline if you can, because, as we discussed, your doctor might not automatically connect your current cognitive complaints to a drug prescribed years ago for allergies or bladder issues unless you explicitly raise the possibility and present your experience. Mentioning the cumulative risk research might also be helpful.
Insist on an honest evaluation of the risk versus benefit for you, specifically considering brain health.
Precisely. Is the short-term symptom relief worth the documented long-term risk to your cognitive future, especially when safer alternatives likely exist? And there's one final point from the source regarding optimizing recovery, especially if you are transitioning off these drugs. It involves nutritional support.
Right. You mentioned nutritional support can help the brain recover. What specifically did the source suggest there?
Yeah, the idea is to support the brain's natural processes like acetylcholine production and neuroplasticity. That's the brain's ability to adapt and rewire itself. The source mentions focusing on things that enhance circulation and support the cholinergic system. For instance, it brings up organic watermelon extract, which is rich in L-citrulline, believed to help with cerebral blood flow and mental clarity. And for more advanced support, particularly during recovery from potential damage, the neurologist mentions protocols involving synergistic ingredients. Things like icarin, often derived from horny goat weed, tungkat ali, fenugreek, nettle root, elements aimed at boosting cognitive function and helping damaged neural pathways recover.
Interesting. So targeted nutrition as a complement to making the medication switch.
Exactly, supporting the brain's own healing mechanisms.
Okay, let's wrap this up. The core takeaway seems crystal clear. Your long-term brain health has to be a priority, right alongside managing your immediate symptoms. Don't just accept observable brain fog or potential future damage at the cost of treatment, especially when brain-safe alternatives are available for almost every condition these anticholinergics are used for.
Absolutely. And that leaves us with perhaps a final provocative thought for you, the listener, to really chew on. Considering this strong link between the cumulative dose, how much and how long you take these drugs, and the increased risk of dementia, how might the incredibly widespread, casual, often decades-long use of common over-the-counter sleep aids, the ones you can buy anywhere, be factoring into the broader public health crisis of cognitive decline we're seeing today? What's the real societal cost when potentially millions of people are minimizing these significant neurological risks night after night, just trying to get a few hours of sleep?
That's a really powerful question to reflect on. Definitely explore the sources, have that conversation with your doctor if this applies to you, and continue this deep dive on your own. We'll see you next time.